Sure. Yeah, I'm ready to get started. Just to give a little bit of background, I currently work at Sharp Hospital. I've been here for a little over 27 years. Um, I do a lot of education. When we were having, before COVID, we held at least two understanding mental health um, groups a day, which coordinated that, and also work with our staff development program with providing mental health education for new employees during their orientation. So I first started working here at the old state hospital, I believe back in 1992. And then we transitioned up here in the new hospital in 1994. Prior to that, experience with homelessness and mental illness, working in a local shelter. So that's just a little bit of background. I have a passion for mental health education and believe that it is more than just information, that it is very much a psychotherapeutic intervention. So I like to support that in my presentation today. If you have any questions, please chat in. If you have any examples, just let me know. I'd like for it to be a little bit interactive if possible. So, okay, given that, we'll go ahead and get started. There's just to kind of review the benefits of the mental health education. It definitely reduces relapse and rehospitalization. There's been a lot of studies on the management of rehospitalizations, and there is a one major study that seemed very productive in Munich, Germany, where they had received from a 58% recidivism rate down to a 40% recidivism rate with individuals with severe mental illness. So that's a pretty good drop with their using psychotherapeutic mental health education. So it's productive, it's financially fiscal to provide mental health education, and it promotes recovery. As things move, what I've noticed is not so much the stigma of other people that are around you that interferes with recovery. It's the self-stigma, the stigma you have about your own illness. So sometimes you can be aware of the stigma that everyone else has, and coming to terms with your own stigma is pretty powerful. So the benefits of the mental health education allows for an opportunity for you to kind of observe that and to kind of become aware of that. All right. And of course, it helps us meet standards, and it can improve insight if it's done well and if it's given time. Sometimes it may not be in that one session that you have with that person, but you're laying groundwork for some understanding and for some communication. And most of the time when I work with insight, you're talking about the illness and about the condition with giving examples. You're not talking about that person and their specific symptoms and examples of their actions that made someone consider a diagnosis of a major psychiatric illness such as schizophrenia and bipolar. So it's where we kind of set that as a neutral place, that we're just talking about those symptoms that are related to the disorder or the illness or the condition. Okay, as opposed to connecting those symptoms to that person, which is more of placing a label on it, and it can kind of make a block with insight as opposed to opening it up. All right. In our next section, kind of want to look at the history of the recovery movement and kind of place that into psychotherapy, mental health education. Historically, kind of in the 60s and 70s, there's almost like there was an advocacy movement, but it was almost like anti-psychiatry, like we're sticking up for individual rights, and it's like the the client, the patient, the person with the mental illness against the person in psychiatry, and psychiatry trying to show that person where they do have a mental illness. And it's kind of like a power struggle. In the future, then it seemed to be more of a nurturing, let's care for it, try to understand. That's a little bit more helpful, but it can be patronizing. And it can, that once that person feels safe and they feel cared for, that person's going to want to continue to be independent and develop their own goals and connect with society. And that nurturing type of thing can be almost like overprotective and not allowing for the individual to be themselves. You know, they're all always under supervision, always under the guidance of the approval or disapproval. And that can make a person feel like they're risking their safety in order to achieve their own goals. So there's a compromise. The people are losing out as opposed to a win-win situation. And then as the recovery movement went, especially in the late 90s, early 2000s, recovery movement became really strong. Consumers, mental health associations, of course, National Alliance for Mental Illness has been NAMI has been along for a really long time, but they became more prominent in the community and more active and more social. So it became, along with Mary Ellen Copeland, which I'll talk to you a little bit about later, but it's more about the person that has experiences of mental illness. I have an experience with the symptoms of schizophrenia and how they relate to me. I'm the expert on that. I'm the expert of what I'm going through. I'm the expert on my story. I'm the expert on how those symptoms personally affect me and how I am, how I choose and how I see recovery. And the clinician is the expert on having the experience of knowing several people that have been through the condition. So if they know something that can help that person, they can present that to them. They're the expert on some of the research, some of this information about medications, information about recovery strategies, therapeutic interventions like cognitive behavioral therapy, mindfulness, motivational interviewing. They may be experts on some of the tools, and them coming together, that's where recovery, they're side by side. Instead of looking at yourself like in an interview room, and looking across the room at each other, you're kind of looking at recovery in front of you, and you're looking at mental illness in front of you, and you're side beside the person. And kind of that's the approach I try to take mentally, is that we're both looking at what that person sees and it's in front of us and they're showing it to us. Does that make sense?
Elizabeth, I hate to interject here. I just wanted to make sure I was on the correct slide.
Oh, I'm
please
sorry.
let me know just anytime you'd like me to advance.
Oh, I went out like a rabbit, didn't I?
No,
Okay.
I just want to make sure I'm doing it correctly.
Sorry. Oh, bloopers. Okay, we are on page 4. Thank you so much. You're so kind in the way you said that. Thank you. All right, we are on page 4 now, which there's not numbered, so that's effective mental health education. So, yeah. Okay. And then that you see relationship versus relational, clarifying the information, using helpful information, and it's clear. Sometimes some of the language that we use is clinical, and it's as if someone's reading it that's not the person, it's not for the person that's experiencing it. It's like for somebody that would study about it. And kind of I look at a lot of information on personal first stories of persons that have experienced schizophrenia, bipolar, depression, anxiety disorders. Those are extremely important. So having clear and helpful language is extremely important. And then the third part is the transition from the symptoms to practical strategies. Okay, this is what it is. Now, what do I do with this information? How do I transition it to recovery? We know that that recovery is not just the absence of symptoms. Recovery is being able to achieve your goals, to connect with the people that you want to connect with, to be able to communicate with you in your own self, and to have the interpersonal communication. So when you looked at the effective strategies on mental health education research, these are the three criteria. You want to be able that rapport, that engagement with a person, of knowing that person's story. Okay, and it's not their story of their illness, it's the story, it's the good story. And when I talk with patients, I ask them to tell me a good day, not the best day in your whole life, just like you on a regular good day. What's that like? And those stories will easily connect you with what they value, what's important to them. And so that's where you want to start. We'll go over Mary Ellen Copeland's, and one of her first questions that she has in her wellness recovery action plan is, what am I like when I'm well? What's that like? Okay. And then the clarification, getting really good information about what those symptoms are and what they look like for the person experiencing them, what they may look like. Talking with, when you just list a list of bullet point symptoms, I don't know what your experience is, but if you do that, it's like someone's like debating you. I don't have this because of this. Well, no, that's not me because of this. And it's just like a whole thing. And I think we would probably do the same thing. Anybody would, saying, okay, these are things you got wrong. Well, no, that's not right. Or you just misunderstand that. And who told you that? That's not accurate. And it doesn't go anywhere. So, but when you talk about, when you really listen to people's stories about their experience, then you come up with a whole gamut of what that might look like. You know, what does paranoia look like? Well, I'm always on guard. I'm trying to protect. I don't want any bad intentions of other people coming against me. And then all of a sudden I feel on guard and I startle and I jump to conclusions. You know, those things are a little bit more helpful than, you're paranoid, right? So we'll get into that in a little bit. But and then the next is practical. All right, now that I have those, how do I cope with them? If I hear voices, what do I do? How do I get to sleep at night? And if I'm having a conversation with someone and they start, what do I do? So given some actually really good recovery strategies. Okay. Going on to the first section on relationship and relational on page 5. It's listening to their stories. We talked a little bit about that. One of the best things I've heard somebody explain bipolar is someone that said, was looking and we were just kind of observing the different things that had happened. And that's what's real important, is to observe without analyzing. And when we did that, the person looked and they said, well, it can all make sense. And that's what a person may tell you. It made sense at the time. And then they're able to pause back and say, yeah, if we come across and say, yeah, it probably did make sense at the time. What I was thinking, it all did seem to make sense. But now looking back, then once you validate that experience, then they're able to be in a safe place where they can look back and going, now looking at it, what does it look like? And that was like a recovery moment for somebody with bipolar. They were able to look at the manic phase and explain all that and say, yeah, I can understand. Because you allowed them to tell their story of what was going on, what they were trying to do. So, and that's why you look at the well within. People don't intentionally go into their life saying, I'm going to trip myself up, make conflicts with people, and try to do everything with my own power. You know, most people don't go into life with trying to destroy their life. You know, they don't try to um, intentionally try to cause harm for themselves. Even causing harm in a suicidation is often, as we know, is a means to get help, to get relief, right? It wasn't always necessarily the intention to die, but I just wanted relief. And that's oftentimes with people's reactions to symptoms is they were trying to get to a good point. And they were reacting normally for anybody that would be experiencing some of the symptoms like hallucinations, delusions, and severe mood changes. So, and the next is we reflect from the transition to the reflection goes from listening to the stories, and then if that person is still disorganized in the speech, if they're still going through mood changes, if they're still having some responses to internal stimuli, it doesn't mean no, wait till they're completely stable to begin that education process. That's where you can begin with a cognitive therapy and helping them organize their thoughts, their feelings, and their actions. And that part itself is the beginning of organization and insight. And I've seen it time and time again. It lays a really good foundation for being able to observe, get off the defensive, allow themselves to look at what's going on around them, and take it out from what's going on ruminating in their mind and get it out where they can do something about it. So when you organize those thoughts, feelings, and actions just by reflection and validating their experience. Okay. The last one we don't give much time for. I don't know, working at Sharp Hospital, most people come to our hospital with handcuffs. You know, it's the only illness I know where you get handcuffed to come to get psychiatric help. I know that's not on an outpatient basis, but sometimes being given a diagnosis seems like a punishment, instead of a way to go, oh wow, I finally have a name for what this is. And that's kind of what I want to look at when people come to the hospital. I'm like, you know, where else are you supposed to get psychiatric mental health education? Where else are you supposed to learn about schizophrenia and bipolar? If not a mental health center, if not a psychiatric hospital. So yeah, we're going to talk about it, but it's your choice to consider what works for you and what doesn't. And opening up to allow them to grieve and recognizing there's a difference between insight and denial. And denial is kind of a natural stage of grief. So the person that's saying they don't have a mental illness, isn't that fairly normal? I mean, some people when they're having heart attacks, they go through a heart attack going, no, it's just indigestion. No, you're having a heart attack, right? So and when the people get angry and they barter, all of those natural stages that go through grief can happen when anybody gets a major diagnosis or has a major life stressor. And when we see that in individuals, instead of seeing it as necessarily part of their illness, as actually seeing it's a normal part of recovery. And that part, we can see that person as well. Now, insight is just not having the awareness. That comes with time, that comes with rapport. And when there's safety there, there's a little bit more opportunity for insight. Okay. All right, we're going to move right on along to discussion. I've talked for a really long time, so help me out here. If you look on the discussion part, sometimes when I look up, if you look up, you're looking up from anywhere from Mayo Clinic to National Institute of Mental Health to NAMI, and you're looking up PDFs of handouts you can give on mental illness. And some of I was like, how am I going to give to a patient or a person with mental illness? Here's information, a chronic disabling condition. Oh, that's inspiring. That's helpful, right? So I don't know what your experience is. If we can just kind of open this up for a little bit of discussion on what are some of the not so helpful language that you've heard that's maybe clinical and even maybe accurate, but is it helpful? So,
Well, I know, and we do trauma. Oops, I have my video up now. We do Trauma 101 and TI PBS, which is trauma informed practices for the PBS program. And in Trauma 101, one of the main things that we hit on in our introduction is how you address your questions of, what's wrong with you. Sometimes, when people come in, your first thing is to ask them, well, what brought you here? Or what's wrong with you? Or, but instead saying, what has happened to you? Asking in that type of question also makes it not sound like their problem is an extension of them, but it's really just what they're experiencing right now is causing it. So that's one example that came to mind instantly.
yeah, those are very helpful. That's very helpful language. Yeah, extremely helpful. Yeah, what's happened to you instead of what's wrong with you.
Yeah.
Trauma-informed care has done a lot to help support mental health. They can work hand in hand.
Mm-hmm.
Anyone else? Anyone else who's tried to look up information to provide for the person, wanting them to have quality, straightforward information? Okay. All right. The next part is the helpful language. I think one of the most helpful words that we use is experiencing what's that experience like. And that tells you, like, for example, that just because a person has a mental illness, those symptoms go into remission. That person necessarily isn't going to have voices 24/7. When you talk about mood swings, that doesn't mean, when you use some of those words like mood swings, you kind of think, what does that person consider? Asking them, when you hear the word mood swings, what does that mean? Do you imagine someone going up and down all the way throughout the day? Because a lot of times things like bipolar are like, possibly 6 months of depression and a week or two of mania, so it's not exactly a rapid swing. And sometimes looking at asking people what they've heard about bipolar, or what they're familiar with that, and then how they define those symptoms. What does that mean to them? And you can beat a lot of stereotypes like that. So another one is sensory based. Knowing that the hallucinations are sensory based. They're not imagination. It's not all in your head. It's not stinking thinking, which is how you can help a person through their thinking by calling it stinking at the same time. Because you've got to be able to have the wellness within that person, that level of thinking, to help that level of thinking to recognize and be aware of where the symptoms are, so that they can communicate to themselves. Not everything that I think or every thought that I have a choice whether I believe that thought or not. And then recognizing that feelings are real, even though they may not be facts. So the other use of metaphors. It seems to be the most helpful. A lot of times when you ask people feelings, they'll give you a metaphor of what they think, and I just run with that. Sometimes we look at things like bipolar seems like a fire hydrant, which going off, and depression seems sometimes like a dripping faucet that's annoying and irritating, and you feel like you just can't stop it. So you want to break the faucet off. And so using metaphors seem to be more person-centered and a little bit more doable than some of the clinical language. All right, the next one is on normalizing symptoms. Okay, all right. If you look at reality kind of, if I would stop and ask you, what is reality? I mean, just kind of everybody knows what it is, but you stop and think, well, how do I describe it? How do I define it? Because I don't know when's the last time someone asked you, what is reality? Any thoughts on that?
And feel free to chat in as well. I'm more than happy to read it out loud.
Okay. If you look at reality as if you look at hallucinations as sensory based, so if they interfere with your senses, that's part of your reality. Your senses tells you what's happening in the here and now. What do I hear, what I see, what I feel, what I can touch. You know, what tells me my reality? Well, we can always say it, if I can hear it, I can see it, I can feel it, I can touch it, then it's real. Then what does that mean to the person that's experiencing hallucinations? That's a real experience. So hallucinations and interfere with the perception of your senses. And it's your life experiences that tell you what your senses mean. It's your life story that tells you that smells, you know, all that makes me feel like, you know, comfort, or like hot coffee or cocoa, or the smell of popcorn. You know, what's those life experiences of some of those smells? What does that tell you? So if you look at reality as consider as your life experiences telling you what your senses mean, what your mood is at the time. For example, if everybody's talking and having a really good time, that could be, hey, this is a great group. And if your mood's good. If you have a headache, you're down, you just got in an argument and you hear everybody talking and laughing and having a good time, it can even make you feel more miserable depending on your mood. So that always puts an umbrella over those life experiences and sensory information. Then it's what you tell yourself. Those experiences, what do I tell myself? What's the explanations for those things that are going on around me? And then what's my reasoning for that? So it's not only the thoughts you have and those experiences have, it's what you tell yourself about what those things mean. And that's where a lot of change can happen. When you look at, well, if reality equals senses over life experiences times mood and what I tell myself, if you want to come up with a formula, then psychosis. Well, if psychosis is changes in your perception to your senses, and it's interfered with by delusions, and you multiply that by your mood, and if you have an extreme mood, where you can get pressured, racing thoughts, rumination, where you can feel a sense of urgency, a sense of importance. Those types of things can affect. So, or extreme depression, where you just want to feel numb, your energy level is low, you're irritable, you feel guilt and shame and trying to figure out why or what that attributes to. Then is what you tell yourself about those things. So is that psychosis? Is that a mental illness? So it seems like if you can put these things in their place, it kind of helps. When I go over what is reality and understanding mental health, I'll ask them, what is that it is? And all those examples will come up and it will fall into those categories. Then it doesn't seem, when you talk about psychosis, then it seems a little bit more doable. If you initially tell someone, well, what's psychosis? Well, you're not in reality. That's not exactly helpful. You know, one of the best things I've heard someone explain Psychosis for them is kind of living in two different realities. So doing things like this tries to help normalize the symptoms and see how it's not so far, delusions and hallucinations are not so far off. There are actually, things that can happen. And they don't make somebody some bizarre or some sensational media type of situation. It's just normalizing those symptoms. The next one is symptoms on a continuum. And knowing that intensity of symptoms, the preoccupation of those symptoms, and the interference of those symptoms have in their life, those can all be on a continuum. And if we look on this, how far could you go up on this realm? Anybody, how far can you go up on this arrow? You've got aware, observation, questioning, cautious, anxiety, suspicious, fear. Has everybody been up there so far with me? Right? If we're honest with ourselves, there's probably been some moments of paranoia. Is delusion so far away? Yeah. And so that's why when someone says they're delusional, it has such a stigma to it. But this kind of says, okay, yeah, I've been there. Okay, maybe that's possible. Maybe these things could happen. So, okay. Move on. All right, so we're going on to what is recovery. So, and again, it says it's not the absence of symptoms. Sometimes when you come in, people learn really quick what the medical provider wants to hear. No suicidal thoughts, nope. No hallucinations, see anything or hear anything no one else sees, nope, good, done, right? If I say yes, that means more medication, right? So it's not a very therapeutic conversation. So being able to define what recovery is beyond the absence of some symptoms is helpful. So going to transitioning to recovery. Okay, there's a 12-step program that the UK has, and I love one of their steps. And it's concerning feelings are real even though they're not factual. So that's the part where we look at the cognitive therapy approach is so helpful because it allows that person to observe their thoughts, feelings, and actions without judging them, just kind of follow where they go, and then recognize they have a choice. That's information. I have a choice whether to believe it. I have a choice to for it to determine the intensity of how I feel about the time. And so that's extremely helpful because the first time you may hear a voice and it's critical and you think like you have to answer, you have to do what the voice tells you to do, and you're trying to barter with it to kind of, okay, how can I get you to leave me alone? What do you want? And so those things can, by recognizing that the feelings are real, you're validating that feeling, not just trying to ignore it, act like it's not there, not trying to appease it, but just saying, yes, I recognize you're here, but this is how I'm going to relate to you. This is how I'm going to relate to the world around me. And that begins with choices. And so that's why I really like that one. Feelings are real, even though they're not factual. One of the best recovery points that a patient had referred to me is, I don't have to believe everything I think. And I said, you know what? That's exactly right. We do that all the day. We're processing information all the time. And so our mood and our symptoms of mood, symptoms of psychosis, they're information. And that can tell us if we're under high stress. That can tell us if we need to back up and kind of observe things. That tells us if we need to get some support. So we can have those symptoms tell us a lot more than just what the contents of what those symptoms are telling us. Okay. How many people are familiar with Mary Ellen Copeland? the WRAP program, Wellness Recovery Action Planning. Anybody familiar with that? No one? Oh, wow. I thought she's internationally known. She started out with a 5-subject notebook, right? And her mom had mental illness. She has a mental illness, and she would go to get help. She recognized the symptoms and she would go to get help until finally she had a communication with her medical provider. He said, was just honest with her. I don't have all the answers. So she realized, she empowered herself to realize that part of that recovery, she was the expert on her. The doctors may be the experts on the medication, on some of the recovery strategies, but she was the expert on what her recovery was going to look like. So she came up with basically 5 divisions. And it basically is, what am I like when I'm doing well? How do I maintain that? When do things get rough? What are some coping strategies? What are my triggers? What are my warning signs? What do I do when things break down? And how do I recognize I'm back to where I want to be? And she's represented in the National Institute of Mental Health. She has her own Wellness Recovery Action Plan company that she has now, but she's gone international, and she's recognized from the Substance Abuse Mental Health Services Administration. And that simple 5-subject notebook has gone a long, long ways, and it is very much evidence-based. So that's one recovery model. And so the next is when ignoring works and when it doesn't work. I don't know how many times have you heard another clinician or even yourself say, just ignore it, or just ignore them. You know what those are, ignore them. Has anybody been pretty familiar with that? Yeah, I don't know if anybody's been on a diet and tried to ignore the chocolate cake in the fridge. It's not so easy, right? So, so you gotta validate it's there. If anybody's watched The Beautiful Mind by John Nash, he recognized and validated what he was seeing, and then he chose that it wasn't going to be part of his life anymore. So when he became aware, he realized, he validated what his experience was, then he made a decision. And that's the important part of ignoring. You can't ignore it like it's not there. I know you're there, and now this is my strategy to how I'm going to cope with you. That's where ignoring can be possible. All right. So, and again, it's given a choice, and you're putting the meaning into what those symptoms mean. What does that mood mean? What does it mean when I feel under pressure? What does it mean that I got a sense of urgency and I can't get people to listen to me? What does it mean when I'm feeling guilt and I'm thinking of all the things that I did wrong and why am I doing that now? What does it mean, when I'm feeling numb? That I just want to be numb and I want relief. Does that mean that life's not living? Or does that mean I just want it to stop? And how do I get help? What's going to help? And then again, going from that divergent to convergent thinking. So just thinking of this problem that's smacking me in the face. Of course, when we do that as clinicians to try to get someone to realize that there's a condition there that needs attention, it's like throwing it in their face. All they can see is the problems, and there's nothing else you can do except push it out of the way. When you're able to share with them and hand to them, you've got this, then you're holding that problem, but you're seeing all the possible solutions. And that's why, divergent thinking is extremely helpful when you're looking at recovery. All right, how are we doing with time?
You're doing perfectly fine. It's 1:12 and the session's until 1:30.
Okay, I'll move it on up. Okay, all right. Celebrating the basics, the small stuff matters. Simple things like sleep, exercise, eating, and healthy. Getting back into that routine. everything that I read from individuals that have experienced illness, it's getting into a routine. And down here I have, there's a difference between a routine and a rut, right? It's not a regimented program that's concrete structure. It's mean that I have, if you have something in planning and you have something on a schedule, your body gets in a rhythm of that. And it's a lot easier to shift mindfully into that next activity because you've got that muscle memory and that rhythm working for you. Most of the time, when you look at triggers, oftentimes they come when people are waiting, when there's something unexpected happening to them, or that they're all their thoughts are overwhelming them. And one of the things that I hear patients say, or people that really experience mental illness that really helps is, I need to get out of my head. So when you get out of your head, what does that mean? Well, it's just focus on what you're doing. Focus on the thoughts that you want to be thinking on. And so, being mindful of when you're walking, noticing the things around you. And that's where those grounding and mindful exercises can help. One of the, a person that was, they said I had to redefine success for myself. And they said, you know what? Me walking out of that front door and getting outside, being willing to get out of my house, that's success for me. And so they redefined success. Early on in the education, we've seen a lot of people when they come in crisis. What is crisis? And then they think of, well, you're a danger to yourself or others. Well, how do we get there? It's usually like I feel my back's against the wall. I'm stuck in a corner. I have no choice, no control. So what's hope? Give myself choices and this type of control, not trying to control and stop, that relaxed control. And that's what routine helps with. That's what, behavior activation and all those types of things is, whether I feel like it or not, I'm going to use this other part of my knowledge that says I'm going to get out there and start walking, or I'm going to get out there and, engage with myself. Again, not engage with myself. I'm so sorry. Engage with other people. I'm going to connect with other people. And it's just such a joy to be able to see that, to see someone that has some of the negative symptoms and they've seen the very basic things. Because I need to get out there and talk to somebody, and realizing sometimes that's a struggle because no one else may talk to them. And if they sit along and they don't engage and they don't transition, that's why some of those mental health cafes and things like that, it just helps you get back into life again. All right, and then self-regulation again is one thing. And how do I deal with those impulses? How do I deal with those feelings of anxiety? I know what's going on, but how do I get out through that? So talking about those coping strategies. Okay. The next, a little bit going back to Marianne Copeland's wrap with a kick. I call it a cognitive kick. And I'll explain to go with that. One of the cognitive strategies is coming up with cognitive coping cards. This has been introduced with substance abuse, with dual diagnosis, and working with, okay, so when I have a craving, what am I telling myself? And when directly looking at a symptom, well, a mood swing, what does that mean? Or depression or anger? Well, what are you saying when you're angry? I get mad and tell everybody, leave me the blank alone. What do they say in exact quotes? And that's what I get. What's that craving? When you're hearing voices, what is that voice exactly saying? What are you thinking about the voice at the same time? And getting whatever that person says in exact quotes of what it says. And that's almost looked at as your automatic thought. And then you're like, okay, this is that difficult, stressful thought. Now what's the recovery thought? Okay. For example, a person may think, I don't want to ever think about recovery planning. I'm not going to use this when I leave here. I want to forget about this place. I don't want to think about it again. And then what's the cognitive coping thought? yeah, this is a difficult place to be, but it's okay to remember the difficult times, but it's also important to remember the recovery times. And having a recovery plan allows me to do this. Does that make sense? So, and then what the voices may say, and that they're critical. And then you think, okay, this is where the strength base comes in. All right, what do you think of yourself? And having them write out exactly some positive strengths they have in sentences, not just listing. And then remember recalling some people that are very important in life. What exactly did that person just say to them that seemed accurate, helpful, and inspiring to them about themselves? And putting those in direct quotes, because you don't remember that stuff when you're stressed out. That goes out the window. All you look at is the crisis that you're in. So that recovery plan and having an exact, yep, there's my symptom. Yep, that's what I'm thinking. That's what I'm experiencing. That's what it is. Okay, then you can center yourself and go, okay, let's try one of these strategies. At least you have something to go to. You've got a strategy to work with. Okay. I think I reviewed the other ones previously. Okay. All right. Working with family. I'll just kind of go over that lightly. I've kind of made it a pattern over time for me to really, I know there can be exceptions to this rule, but I really prefer, if I'm talking with family, that the person who is experiencing the mental illness, the patient or the client that I have with me, is right there with me. Okay, it helps decrease a lot of paranoia. It helps build trust. The one other main point is usually when I'm meeting with family about education on both ends. I have them write down, just like, what do you like when you're well? What are your strengths? What do you want to see that you recognize as good? What times did you share together? And maybe even give an example of those times. And then their expectations. What's got to stop? This isn't helpful. And have that on both sides, especially if people are returning to live in a home where there is, escalation of the symptoms, and then family members may have gotten hurt, or the person experiencing mental illness may have gotten hurt. Understanding that, hey, we can't walk on eggshells, right? And then helping in people transition from that parent-child to that adult-child, adult-parent, and that's not always easy. One of the things is to recognize is that some people may not tell you right off. They may not want to tell you that their parent had bipolar or their parent had schizophrenia. So sometimes when they say, I don't have bipolar, or I don't have schizophrenia, what they're saying is, that was my mom and I'm not like her. There's no way I have that disorder. I am not like her. I'm not going to be like her. And that often happens with a person the other day said, you were kind of using that downward arrow technique with the cognitive therapy. And what did that mean? Well, what does that mean? What are the side effects? And what does that cause? What does that interfere with? And just doing that downward arrow till they finally say, and they get to the point, my family member was on medication for years and they may not have had a positive experience. Those individuals may not have been part of the recovery movement. And so they're seeing that their parent went through a mental illness wasn't helpful. And they see themselves going through that same thing. They don't want to go there. They don't want to go that route. So recognizing, making sure you get the story and where those things are coming from, and understanding that each person's experience with mental illness is a little bit different and unique to them. And the prognosis and the recovery is going to be individual and unique to them as well. So, okay, real quickly, there's some resources at the end. Bring Change to Mind has some wonderful, it's Glenn Close and Ron Howard. If you can look at some of those videos and help share with family members and with other people, I think it's some of the best production of many public service announcements on mental health that there is. Glenn Close has done a lot of good work for recovery. Bipolar Hope has some real practical information for individuals. It's Bipolar Hope magazine. It's BP Hope. It's an excellent resource. And another book. I don't know if anybody, yeah, you guys can see me. This book, it's like you would think you would buy it on a drugstore rack, like How to Be a Better Person in 10 Days. But it is evidence-based. Their research is in National Institute of Mental Health, and it's the names of Freeman and Garrity. And it is one of the best books on suspicious and paranoid thoughts. I have done groups on it where patients do not leave my group. They stick with it through 20-some sessions because it works. I've had patients ask for the book, like I'm on my last copy, and that's like out of 30 books. So that people ask for it and they accept it. Not everyone's going to go for it, but it has a lot of cognitive approaches to dealing with paranoid suspicious thoughts, whether if that's related to psychosis or if it's related to anxiety and mood. They often, what's the most interesting, and you'll see people study it, is they have the survey in the front that shows all the people that have paranoid suspicious thoughts and all the different examples of them, and then how many people out of that survey thought this thought. So this is one thing that says you're not alone. Look how many people have experienced the same thing. All right, there's a name for it, you know. And then they have practical strategies and how to work with those thoughts so they don't intrude on your day-to-day life. But it definitely is one I probably wrote or read it probably like 6 times because you read it with your group. It is, if you get nothing else out of this, Freeman and Garrity's Overcoming Paranoid and Suspicious Thoughts. And I'm not, you know, I don't have any financial, I'm just saying it's a good resource. So, all right, thank you for your time. I appreciate that. If there's any questions or concerns or any feedback, just let me know.
Thank you so much, Elizabeth. That was a wonderful presentation and such an important one to share with a wider group, you know, so we truly appreciate your time, and the list of resources were also wonderful. We did get a chat in asking what the name of the book was.
Oh, it's called Overcoming Paranoid and Suspicious Thoughts. It's a 2nd edition. It's on Amazon. I think it's even on Walmart.
Okay, excellent.
Yeah, and Freeman and Garrity are very well respected. You can look up at their journal articles, and they actually have a website and you can complete the survey yourself. So
awesome. Thank you so much, Elizabeth. And Elizabeth Minnick with an S actually chatted in as well too. So thank you for chatting in that the title of that book. Were there any
$25? It's not bad.
Thank you. Were there any other thoughts or questions from the group as a whole for Elizabeth and her presentation? We got a chat in from Amanda thanking you and saying that she loves the catch it, check it, and change it.
yeah.
Alrighty, well, thank you all so much for joining today's session. And again, huge shout out to Elizabeth for presenting for us today. We really appreciate it very much. I'll be sure to include your PowerPoint in the recap email that I send out, along with the title of that book. So if anyone wants to check it out, they're more than welcome to. All right, so the only announcement that I have is that our next session will be on October 6th, and Dr. Swagger will be presenting on understanding school services. So keep an eye out for that reminder. As always, if there are any questions after the fact, anything to do with ECHO or other things, you're more than welcome to reach out to Elizabeth and I, and we will respond to you as soon as we can. Thank you all again, and we'll see you guys next time. Take care.